Welcome to part 3 of the Charette adjusting protocols. I'm Dr. Charette. In this section, I'll go over the TMJ, ribs, show and feel demonstrations, and all the home exercises. Let's get started. This rib adjustment is for the anterior subluxation of the rib head. This subluxation usually occurs somewhere between T3 and about T9. To locate this subluxation, the doctor will take the finger pads in this manner and palpate along the rib heads. If this subluxation is present, the doctor will find a palpable anteriority almost always over a very tender area. The adjustment is done by taking the thenar of the doctor's back hand and contacting the rib head. A tissue pull is taken from lateral to medial so that the thenar then is located over the transverse process of the appropriate vertebra. The doctor then has the patient contact the palm on the lateral cervicals in this manner. The doctor's flat palm will contact the anterior deltoid. The patient is then instructed to lie back with the head touching the table. The doctor will then have the patient take a deep breath in and let it all the way out, and the doctor will thrust in an A to P direction toward his or her thenar. A typical audible release is usually heard on this adjustment. This rib adjustment is for the costrosternal and costochondral areas. The direction of subluxation in this misalignment is not one of posteriority or anteriority, but instead an overlapping. The doctor will locate this subluxation via palpation. It will usually be under a tender area with the doctor feeling some degree of overlapping of the rib. The adjustment for this subluxation is to take two fingers and straddle either side of the rib like this on both sides of the subluxation. The doctor will then distract in this manner very firmly 4 to 5 times on either the costochondral or the costrosternal area. A variation of this technique has the doctor placing one of the thenars on the contact with the 2 index fingers straddling the rib, and again with 4 or 5 strong distractions lining the rib back up on either the costrosternal or, in this case, the costochondral area. The next area that we'll consider is the temporomandibular joint, the TMJ. It has been my experience that soft tissue preparation is required in order to have this adjustment hold for a longer period of time. The typical subluxation pattern in the TMJ is for the TMJ to subluxate in a posterior and superior direction combined with some laterality. To find the laterality, the doctor will place the fingertips over the TMJ and have the patient open and close the mouth several times about halfway. Open and close, and open and close. The doctor will feel a bulging along the finger pads on the side of any lateral component. Next, the doctor will prepare the tissue. The first thing that we will do is to do a stretching of the posterior cervical muscles in a superior to inferior direction 4 to 5 times, first on the right side and then on the left side. After this, the doctor will stretch the sternocleidomastoid muscle. in this direction. Again, 4 to 5 stretches, first on the right side and then on the left side. After the sternocleidomastoid, we will stretch the platysma. What the doctor needs to do is to take the heel of the hand and place it on the clavicle area with the finger pads like you see here. And again, with a 4 or 5 repetition stretch, stretching the platysma like this. First on the right side and then on the left side. What we'll do next is to do a series of trigger points along the temporalis, buccinator, and masseter areas using the finger pads in a circular pattern like you see here. Again, these trigger points are done first on the right side and then on the left side. First temporalis, then the buccinator and masseter areas. The next area to be stretched will be the atlanto-occipital area. The doctor will take the thenar area of the hand, place it on the mastoid with the fingertips here, stretching in this direction. Again, approximately 4 to 5 repetitions on the right, followed by 4 to 5 repetitions on the left. And the last stretch that we'll do prior to adjusting the jaw is to next stretch the temporomandibular joint area itself, as you see here, with 4 to 5 repetitions, first on the right side and then on the left side. The next area to be dealt with is the tendon of the lateral pterygoid muscle, located approximately right here. What the doctor will do is to place a finger cot on the index finger like this. The doctor will then have the patient relax the jaw, open the mouth approximately halfway. The doctor will then place the index finger between the teeth and the cheek and roll the lateral pterygoid tendon externally like this 3 to 4 times. Open the mouth, relax the jaw, and again with 3 or 4 repetitions, the doctor will release the lateral pterygoid, which is usually tender to the patient. Now to adjust the temporomandibular joint. In review, the direction of subluxation is for the mandible to subluxate in a posterior and superior direction. This patient also has left laterality. The way that we will adjust this joint is to have the assistant stabilize the patient's head in this manner. The doctor will then apply finger cots to both thumbs as shown here. The doctor will then place the thumbs on the patient's lower molars. The doctor then pulls the patient's mandible inferior, anterior, and the side opposite of laterality, which in this case is to the right. With the patient's jaw in this position, the doctor will then do several small figure-8 motions to stimulate proprioception. After the doctor does several figure-8 motions, the doctor will then remove the thumbs from the patient's mouth and instruct the patient to hold the bottom teeth in front of the top teeth. Mrs. Jones, relax your jaw and open your mouth approximately halfway. With the thumbs on the lower molars, the doctor will then grasp the jaw in this manner and pull inferior, anterior, and the side opposite laterality, then small figure-8 motions. After the figure-8 motions, the doctor will remove the thumbs from the mouth and instruct the patient to hold the bottom teeth in front of the top teeth like this. The assistant then removes the hands and the doctor will milk the TMJ superior to inferior several times as the patient relaxes the jaw. After the jaw has been adjusted and most symptoms have subsided, it's important to strengthen this area. I recommend an exercise where the patient's thumb contacts the chin like this. The idea here is to move the chin forward as the thumb provides resistance backwards. The motion is like this. The patient is instructed to do 20 repetitions morning and evening, making sure that the exercise does not create any jaw symptoms or tenderness. Many times it's difficult for the chiropractor to explain to the patient that the reason that the adjustments are not holding as long or as well as hoped is because the soft tissue retaining mechanism has been plastically deformed. Plantar fascia, sacroiliac joints will plastically deform over a period of time, and here's a good way to explain to the patient how that's happening. I use some plastic wrap or a plastic bag, give it to the patient, and have them pull. This will show, like ligaments, sacroiliac joints, plantar fascia, that they can become plastically deformed and lengthened. This will show the patient a need for bracing, orthotics, and even corrective exercises. This next demonstration, the knock-kneed bow-legged demonstration, is to show the patient the effects of excessive pronation and excessive supination on hip motion. For this demonstration, the doctor will instruct the patient to put the 4 flat finger pads on a broad contact on the greater trochanters as shown here. Then, with the patient standing with the feet shoulder-width apart, the doctor will instruct the patient to first knock the knees, which will excessively pronate the feet, then to bow the legs, which will excessively supinate the feet. The doctor then instructs the patient to do this several times, exaggerating the pronation and supination by knocking and bowing the legs. The second part of this exercise will show the patient that only minimal motion can affect hip motion. On this, the doctor will have the patient put the flat finger pads on just one hip. On this one, the doctor will then instruct the patient to wiggle the foot out and in minimally, and then bring the patient's attention to the motion under their finger pads on the hip socket. This next demonstration is pelvic rotation and the relationship it has to pronating and supinating feet. On this demonstration, the doctor will have the patient stand with the feet shoulder-width apart. The doctor will instruct the patient to rotate the hips as far as he or she can and hold it in that position as shown right here. The doctor will then bring the patient's attention to the feet. Notice in this case how the right foot is excessively pronating and the left foot is excessively supinating. Therefore, it is extremely important, in my opinion, that the doctor adjusts the spine prior to adjusting the feet, knees, and hips. The most common postural distortion on the planet is anterior cervical translation. It is my strong opinion that it is extremely difficult to get long-term stability in wrists, elbows, and shoulders when there's anterior translation of the cervical spine greater than 1 inch. I'm going to show you 4 demonstrations now that will show you that lung capacity, cervical rotation, cervical extension, and even shoulder abduction can be restricted with anterior cervical translation. The first demo will address lung capacity. On this demonstration, have the patient picture railroad tracks coming out the chin. have the patient extend the chin out onto the railroad tracks as far as he or she can. Then instruct the patient to take a deep breath in and let it all the way out. Then have them bring the ear over the AC joint and again take a deep breath in and let it all the way out. The patient will notice an increase in lung capacity and ease of breathing when the ear is over the AC joint. Next, let's talk about cervical rotation. Cervical rotation can also be restricted with anterior translation greater than 1 inch. On this demonstration, have the patient again bring the chin out onto the railroad tracks as far as the patient can. Then rotate the head as far as you can to the right, as far as you can to the left. On the second portion, have the ear over the AC joint and again rotate as far as you can to the right and as far as you can to the left. The patient will notice that it's much easier to rotate the cervical spine when the ear is over the AC joint. The next demonstration is for cervical extension. On this demonstration, have the patient anteriorly translate the cervical spine out onto the railroad tracks. Then extend the cervical spine as far as the patient can. You'll notice in some cases it almost locks extension. On the second portion, have the ear over the AC joint and again extend the cervical spine. A dramatic change is noted in most patients that it is much easier to extend the cervical spine with the ear over the AC joint. The last thing I'd like to show you is how shoulder abduction can be restricted with anterior cervical translation. On this demonstration, have the patient anteriorly translate the cervical spine to the limit. Then with the arms straight, raise them up, abducting the shoulders. Then on the second portion, have the ear over the AC joint and again have the patient raise the arms up, and it's a dramatic change when the ear is over the AC joint. Hopefully these 4 demonstrations will help you show your patients the importance of doing posterior translation against resistance to get the ear over the AC joint. Another home exercise that can be utilized for the knee is with the Therasizer. It's called leg extension. If the listing for the knee is a medial condyle, the patient will internally rotate the foot as shown. Then extend the entire leg. This will help isolate the vastus lateralis muscle of the quadriceps. I recommend 20 repetitions twice daily for a 2-month period. If the listing is a lateral condyle, the patient will externally rotate the foot as shown, literally pointing the toes toward the lateral condyle, then extending the leg 20 repetitions morning and evening for approximately 2 months. This will help isolate the vastus medialis muscle of the quadriceps group. The primary rehab exercise for the shoulders is the scapular squeeze. In this exercise, the patient will raise the arms at a 90-degree angle in this manner. Then approximate the medial borders of the scapula like this. It is very important not to move the arms in this exercise. Only the scapula should move. I recommend 20 repetitions twice a day for 2 months. Another targeted rehab exercise for the shoulder is the external rotator exercise. In this exercise, the patient places the hand and the loop of the Therasizer in this manner, with the patient's elbow tight into the belt line. This exercise will utilize the external shoulder rotators, which are the infraspinatus and the teres minor muscles. The mechanics of this exercise are like this, with the patient externally rotating the shoulder. I recommend 20 repetitions twice daily for a 2-month period. The targeted rehab exercise for the elbow is the pronator teres exercise. In this exercise, the patient will place the hand in the loop of the Therasizer in this manner. Then what the patient does is pronates the entire wrist and forearm like this. I recommend 20 repetitions twice a day for 2 months. Another exercise that can be utilized for wrist rehabilitation at home is the wrist extension exercise. I'm going to demonstrate using a Therasizer from Foot Levelers. One end of the Therasizer is attached into the door and the loop is placed around the patient's hand like this. The patient is going to extend the wrist in this manner. This exercise will utilize the extensor cartilage